There are histidine-rich proteins sort of negative falciparum malaria that exist. It's a small proportion in India as compared to sub-Saharan Africa. I think this is sort of, when we talk about maybe, enteric fever, I think traditionally blood culture should be the gold standard for diagnosing enteric fever and probably should be the only method used to rule in, not to rule out.
Sickle cell disease is predominant. A fever in a patient with sickle cell disease, which sometimes remains undiagnosed. Nowadays, we are seeing more dengue patients. So it's being transitioned from urban settings to the semi-urban and now also coming to rural areas.
Welcome to CSA Podcast. The Community Science Alliance, or CSA, is a partnership of community-based organizations, clinicians and researchers advancing the science and practice of contextually relevant evidence-based medicine in resource-limited settings. The CSA Podcast builds on our focus in primary healthcare. I am Dr. Charuta Mandke from the CSA, and I invite you to enjoy these podcasts which cover common disease entities.
This is the CSA Podcast, presented by Social Alpha.
Welcome to the CSA Podcasts. These podcasts are dedicated to empowering doctors and medical residents in resource-poor areas with the latest in medical knowledge and practice. Today, we are delving into a crucial topic, acute undifferentiated febrile illness, and its management in under-resourced settings. So as a way of introduction, I'll basically, go over two case scenarios, which we'll come back to in the end after we've discussed the approach to a patient who presents with symptoms. And then we will, these case scenarios will help doctors apply the pathways in different scenarios. And the diagnosis that we will consider include suspected malaria, dengue, enteric fever, or other febrile illnesses. And they reflect the document's guidance on assessment of symptoms, testing, and any sort of treatment, including empiric treatment choices. So as an example, and keep these in mind, we'll come back to these case scenarios in the end. You don't have to remember the details, we go over them. So case one is a 35-year-old farm worker from rural West Bengal. And he presents with a 5-day history of high-grade fevers with chills and severe headache. And he denies any cough, diarrhea, or urinary symptoms. On physical exam, he appears dehydrated with a temperature of 102 degrees Fahrenheit. He's tachycardic with a heart rate of 110 beats per minute, and his blood pressure is slightly low at 90/60. And so that's case one. And then case two is a 28-year-old pregnant woman from a temporary tenement dwelling in Mumbai who comes to the clinic with a 7-day history of fever, severe myalgias, and a maculopapular rash on her arms and legs. She's febrile to a temperature of 101 degrees Fahrenheit. She appears ill, but is overall hemodynamically very stable. And there are some blood tests that are done that reveal thrombocytopenia, and a platelet count is 80,000 per microliter. So with those cases in mind, we will go ahead with our podcast. So I'll introduce myself. My name is Shiva Kumar Narayanan. I go by Shiva. I'm an assistant professor of medicine at the Institute of Human Virology at the University of Maryland, School of Medicine in Baltimore, Maryland. By way of my credentials, I graduated with an MBBS at the PJ Medical College, Pune, India. And then I did my residency training at the KEM Hospital and CGS Medical College in Mumbai. And I trained in infectious diseases at the University of Maryland, and I currently have served there as faculty. And I'm currently in conversation with Dr. Phutke, Gajanan Phutke. So I'll allow Dr. Phutke to introduce himself.
Hi, sure. So I'm Dr. Gajanan, and I work as a faculty in Department of Family Medicine here at Janswas Sayog Bilaspur. And I also have an interest in working in community medicine. So I also supervise our community health program, which is spread on 72 villages and 40,000 population.
Welcome, Gajanan. So it's a pleasure to discuss this very important topic with you.
Yeah, sure. So let us start with the basics, Shiva. So I would like to ask, what is an adult undifferentiated acute fever, and why is it a significant concern in India?
Absolutely. So by way of definition, I think there are many parts to the definition, and we always want to sort of define something so that we can approach it in a better way. But broadly, an acute undifferentiated febrile episode or fever, it represents a fever that is manifest for at least a duration of between 3 to 14 to sometimes 21 days without any clear localizing symptoms. that would suggest an immediate diagnosis. And by fever, we conventionally mean, 2 consecutive temperature readings that are 38.3 degrees Celsius or higher. In Fahrenheit, that's 100.9 degrees Fahrenheit. And I know it's hot in India without evidence of an environmental cause. So this is an endogenous fever. And the 3-day to 21-day or 3-day to 14-day duration is basically because most viral acute febrile episodes, which contribute to a vast majority of fever episodes, they usually are self-limited and will resolve in around 3 days. And fever beyond 21 days is usually within the FUO definition. That's assuming that a reasonable workup has been done. And it's a major concern because infectious diseases are a leading cause of morbidity and mortality in the country. And by the global burden of disease estimates, still respiratory and enteric infections are pretty high in terms of number of mortalities or disability adjusted life years in India. And if you look at the literature, it is estimated that one adult, and again we're talking about adults here, but one adult resident in tropics will experience around 4 febrile episodes per year in the rural area and around 0.5 febrile episodes per year in the urban residents. It's probably higher in kids. And a vast majority of these are caused by bacterial and viral infections. And despite the fact that they're so common, there are a number of challenges that present, that a diagnostician or a physician who, these patients might approach, might face. And one of the reasons being because, you have the term undifferentiated, the presentation might be relatively non-specific. So at least in the acute phase, you might think of something like enteric fever, which is sort of, elusive to diagnose in the first year sometimes. And even the most astute diagnostician might not necessarily be able to sort of accurately, immediately diagnose these conditions. And, in addition, in underserved communities where you might have difficulty for patients to approach physicians, they might approach a mid-level provider, a nurse midwife, or a pharmacist. And the temptation there is to sort of shortcut and prescribe antibiotics, which might both be, completely unnecessary, but they might also not be effective. And, in the long run, we always worry about antimicrobial misuse and drug resistance. And India gets the flack sometimes in terms of like the high prevalence of community SBLs and other drug-resistant bacteria. And, I think in many ways, these undifferentiated febrile illnesses inappropriately managed contribute to the burden of, antimicrobial resistance. And you might say that there is the National Enteric Fever Surveillance System. The results were reported in the NEJM recently, or other surveillance systems, but they lack in terms of either staffing. There's no dedicated public health cadre in India, or the magnitude, or even reporting at a local level sort of is very variable and depends on manpower. And so I think what ends up happening is, a community provider might not be able to have background information as to what's going on. And also, when somebody approaches a provider in a rural setting, there's a vast heterogeneity in terms of both geographical sort of distribution of causes as well as resources. So what might be available to a provider in urban Mumbai might be very different than what's available in GSS. And so I think there cannot be one uniform approach in terms of either the pathogen or the testing approach or even the empiric choices in the management of these conditions. So this makes it very difficult, for an individual provider to approach, diagnose, and treat these conditions. So that's sort of the challenge and why it's very significant that we talk about this.
Yeah, sure. That's very comprehensive. So can you give us an overview about the common causes of acute undifferentiated fever illness in India? And as you said, there are different reasons in different geographies and especially different seasons. So can you briefly also talk about the epidemiology?
Absolutely. So I think, there is broadly, based on published literature and, the prevalence rates, you can classify acute undifferentiated fevers as malarial and non-malarial. And the reason is twofold. I think if you look at causes that are described, for most cases of acute undifferentiated febrile illnesses, that are severe and then severe enough that they present to a healthcare provider in an LMIC setting. Malaria and dengue sort of represent a large proportion of the diagnosed conditions. So they range, in prevalence in both like sub-Saharan Africa and South and Southeast Asia. They contribute around 25 to 50% of all cases that are diagnosed. Now, bear in mind, a large majority are, might not be diagnosed too, but they probably represent brief viral infections. And then two, I think the rapid diagnostic sort of pathway with malaria has emerged more or is more refined and more accurate than, sometimes the serologic tests that are used to diagnose conditions like, let's say, leptospirosis or scrub typhus or chikungunya. And I think when one depends on serologic tests, we are limited by sensitivity and specificity, both in terms of true positives and negatives, but also sensitivity and specificity in different phases of the immune response, which leads to a number of, false positives and false negatives. Malaria is obviously a significant concern. Every medical student that trains through India sort of learns about, falciparum and vivax malaria, where they're prevalent. And falciparum is predominant in India, probably in the east, northeast, and vivax malaria probably more in the central and southern regions. Amongst non-malarial causes, dengue fever is sort of emergent, and it's sort of and its epidemiology is evolving over time. But higher cases are probably reported because of where the Aedes, mosquito lives in probably more urban areas, and in the south, west, northeast, east. I mean, essentially all over. But it maybe the cases might rise during the monsoon season when the mosquito burden in the environment also increases. And in hyperendemic areas, certainly in Mumbai where I trained, I mean, it's sort of all year round. I mean, it doesn't necessarily, unless it's like super cold, which is very rare. And enteric and typhoid fever is probably a little bit more urban, and it, the cases dramatically rise in the July to October period. Leptospirosis also seems to have, a predominance in urban areas, but leptospirosis is transmitted by Leptospira ictrohemorrhagicae, which is a spirochete, and which resides in the in mice as their hosts and is excreted in the mouse urine. And so the route of transmission is contaminated wounds that are in contact with water that is contaminated with rodent urine or animal urine. And so you might see a surge in cases in urban areas when there is flooding and lack of wastewater management. And it's very similar, though the distribution of cases might sort of vary with scrub typhus, which is a rickettsial illness. So when you look at the literature, most cases are described in the Himalayan footlands or the northeastern or rural areas. So also in south, there is a case series from CMC. And most of these cases affect agricultural labors. There is a rodent connection, of course, but it's, the transmission is by mites that live on the bodies of these rodents. Very challenging to diagnose and needs a high degree of suspicion, to test and treat. And, over time, we've seen conditions like chikungunya, which emerge in sort of clusters, and, high cases were reported in Karnataka, Maharashtra, Telangana, Uttar Pradesh during the rainy season. Again, very difficult sometimes to differentiate from dengue fever. And, as the saying goes, if you don't know, you don't know. And so if you don't test and if you don't suspect, you might never be able to diagnose. I think what we'll also focus on when we discuss, the management is the fact that many acute undifferentiated febrile illness would actually sort of be organ-specific infections like a UTI or, an intra-abdominal infection, a cholecystitis, or even in India, you can't not talk about TB. So, somebody with a TB pleural effusion or even acute HIV who might sort of present with a non-differentiated, non-localizing sort of fever syndrome. So that's, I've tried to, cover most. I mean, of course, the list is exhaustive, but these are the most common causes that one should sort of keep in mind.
Yeah, Shiva. So that's a great list. I would say like malaria, enteric fever, leptospirosis, scrub, chikungunya, COVID, influenza, and like acute infections of tuberculosis and HIV. So this is a big list. And like in resource poor settings, the diagnostic facilities are limited, and the turnaround time for the test is high. So in this scenario, how would you recommend the clinician approach the diagnosis and management of acute undifferentiated fever?
That's a great question. How do you approach the diagnosis when you don't have the resources? And I think our best resources are a good history and physical exam and building a differential diagnosis and elimination. And we have having been in two settings, I can say that physicians in India, we get a huge emphasis on history and physical exam. Of course, prior to that, few basic things. Make sure your patient is stable. Do a triage of the severity of the illness and make sure they don't need sort of any acute resuscitation or stabilization before you go on with your diagnostic workup. And people could use the temperature, pulse, respiration, and blood pressure with a quasi-NEWS2 or a QSOFA criteria to sort of determine who's the person that I need to sort of resuscitate before I carry on with the workup? Or do they look dehydrated? Is their skin dented? Is their tongue looking coated or furry? Or are they acidotic? Or do they have air hunger? Or are they breathing with air hunger or showing accessory muscles of respiration use? When we train medical students, we sort of try to tell them you assess their ABC. I mean, this of course pertains to the acute resuscitation. So are they protecting their airway? Do you need to secure it? If they're hypoperfused, do they need fluid resuscitation? Once you've stabilized, then you might sort of focus on your diagnostic process. And when somebody approaches a person with fever, I think we always talk about origin, duration, and progress, right? So the infectious syndromes are how people qualify that might hold a lot of clues. Malarial fevers are described as paroxysms with chills, but we do understand that people with pyelonephritis or bacteremia might also have chills. This pertains to gram-negative bacteremia. Salmonella is sort of a weird one. It has a very low-level bacteremia and sort of presents not in a sepsis, hypotension type of presentation, except when somebody's in week 3, or an acute cholecystitis. People might be inappropriately tachycardic, which might sort of indicate, myocarditis or hypoxia. And so also tachypnea might indicate that they have metabolic acidosis or signs of pneumonia or sepsis. And mental status changes could be subtle, but they could be profound. And besides meningitis or encephalitis, I mean, certainly if you're in the Japanese encephalitis belt, you're suspecting that. But then people with cerebral malaria might sort of present with jaundice and mental status changes, also typhoid encephalopathy in the 3rd week. And scrub typhus does have a higher risk of severe presentation if it's not managed appropriately early on. So that has to be sort of borne in mind. I think in the context of the ODP, the origin, duration of progress, it's important to sort of also assess their background medical history. So does this patient have HIV, which then puts them at risk of other opportunistic infections, or they have alcoholism, which is immune suppressive, or do they have liver cirrhosis, which might raise the prospect of spontaneous bacterial peritonitis, or even female or woman of childbearing age, are they pregnant, which could mean they could have pyelonephritis. All of these sort of come into your history gathering, and I think we look upon history as separate from diagnosis, but bear in mind the history and physical exam is a part of your iterative hypothesis testing process, where you're constantly asking the next question based on data from the previous question to sort of refine your pre-test probability so that you can test appropriately, right?
Yeah. Thanks, Shiva. Thanks for emphasizing on history points, because this is a topic where the history points are very much important and they can give us very much important clues. And now going ahead, are there any physical exam signs which are similarly helpful, like a detailed history, like a detailed physical examination?
Yeah, I think there is a wealth of information that can be gathered from the physical exam. And again, I think since you don't have many positives, a similar head-to-toe sort of approach is very useful. So for example, check for neck stiffness if they have meningitis. Again, neck stiffness might be sensitive, but it's not very specific in that sense. And bear in mind, I mean, as a resource, I would like to suggest, at least for medical students, there's this great book by Stephen McGee called Evidence-Based Physical Diagnosis. And it sort of gives you the soft signs and the hard signs of the physical exam. And it's very useful to sort of look at that in perspective, I think. But in the fever context, there are some signs that are highly hard signs are very reliable. And so their positive likelihood ratio is very high. So for example, when you see somebody who's febrile and has jaundice, that might be a sign of either malarial hepatitis or leptospirosis or, intravascular hemolysis if somebody has, black water fever, as we used to call it. Conjunctival suffusion seems to be sort of rather specific for leptospirosis and is reliable to sort of elevate your pre-test suspicion for testing or treatment for leptospirosis. People with dengue sort of present with a rash. Again, you might not notice this in somebody who's dark skinned, but sometimes you can sort of look for signs of thrombocytopenia in the form of petechiae. One site to look for is the palate. Sometimes palatal petechiae might present in viral exanthems. When you're looking at the throat, also look for if there is pharyngeal exudates or vesicular lesions. They might sort of point to a viral, syndrome or strep pharyngitis. While you're looking in the mouth, also look for if the patient has thrush. I think, that's sometimes the first indicator that somebody might be HIV positive and they're immune suppressed. Palpate for neck lymph nodes. If you suspect tuberculosis, listen to the heart and lungs. You might auscultate a murmur of acute rheumatic fever, perhaps, or bronchial breath sounds or egophony, which might indicate that the patient has pneumonia. Now, I trained with some physicians who were diagnosticians, and they used to sort of pride the ability to differentiate between like a malarial spleen and a typhoidal spleen on abdominal examination. I think in my mind, when I was a resident in KM Hospital, my reflex when admitting 60 plus patients to KM Hospital during the monsoon season was to go under the left costal margin and feel if this spleen is firm or soft, which sort of helps differentiate malarial typhoidal spleen. But also the right upper quadrant, they have cholecystitis. And again, another hard sign is probably renal angle tenderness. Patients who are pregnant who present with nausea, vomiting, and fever might actually have pyelonephritis. So feel for if there is renal angle tenderness. It might be a pretty reliable sign in the appropriate context. And so also, do an extremity exam, feel for joint pain or joint tenderness without effusion. Patients with dengue might have like this diffuse blanchable erythema. And sometimes you have to look at the back to sort of feel that. You might imprint your palm onto the back and you might see that there is a blanchable erythema, and that might be a sign to sort of suspect dengue when somebody presents with a non-specific presentation. And, at the end of the history and physical exam, the goal is that you approach with a broader differential diagnosis, and then you narrow it down to, 5, 7, whatever number of, diagnoses that you have in mind at the end of the physical examination. And of course, you might still be drawing null at this point of time. But, what this helps is, at this time, you've sort of called your staff or, sent blood work, but it's useful to differentiate febrile illnesses into fever syndromes.
Yeah. Very comprehensive, Shiva. So here, just I would like to add one more thing in the belt where sickle cell disease is predominant, a fever with in a patient with sickle cell disease, which sometimes remains undiagnosed. So there, a sickle crisis or a patient with sickle cell disease, they usually don't have spleen, but they can be jaundice. So that is another differentiator apart from malaria or leptospirosis for the fever.
That's great. Yeah, absolutely. Yeah. Again, goes to the point where you have to have, the context sort of matters, and sort of Mumbai and Bihar or Chhattisgarh might be very different in terms of, the conditions that you're going to suspect and work up.
Absolutely. Like we do often see these scenarios that despite the detailed history and detailed physical examination, we end up not getting many clues. And this is not uncommon. So like what initial workup would you suggest in such a situation?
I think it's important to be judicious too, right? I mean, if you don't have the resources, then make sure that you test appropriately, right? So I think if you were to use a shotgun approach, maybe you can diagnose everybody. And, we see that certainly with resource-rich settings where you might have a shotgun multiplex PCR and be able to diagnose somebody with human metapneumovirus. But then when you are in a setting where you don't have the resource, it's important to sort of choose wisely, as the American College of Physicians likes to say. So initial investigations would probably involve a CBC and a renal and a kidney panel. The reason being that this helps you differentiate between these different syndromes. So certainly a thrombocytopenia with fever is useful. It might also reveal elevated liver function test, which helps you sort of go along the fever with hepatitis or hepatorenal sort of pathway. Leukopenia can be a sign of, viral, arboviral, alpha, or flavivirus, so dengue and chikungunya. But thrombocytopenia can also sort of occur with severe malaria as well as leptospirosis. But then, you're sort of seeing other signs. You might see a hepatitis, or you might see, signs of intravascular hemolysis. Enteric fever also variously, if you look at the literature, most cases or significant number of cases will have an elevation of LFTs. And the LFT elevation is not in the range of the thousands like we see in viral hepatitis, but more in the 200 to 400 sort of range. And the bilirubin elevation is also high. You might see a bilirubin of 2 to 4 with transaminases of around 300, with a patient presenting with severe conjunctival suffusion, muscle pain, and then so that might sort of point to working up for leptospirosis, for example. At this point, you would probably also want to sort of work along a pathway of, do I want to exclude malaria? And I think, at this point, you need to leverage your reliability of the malarial rapid diagnostic test. Certainly, if you're in a malarial belt, more urgently so. And then possibly also dengue, because as we know, dengue sort of emerging as a pan, world or pan India sort of, cause for acute undifferentiated fever. And then obviously, if you're, seeing a high number of background COVID cases or influenza, use a rapid diagnostic test to sort of rule out if that is appropriate or if it is available, obviously. And then at this point, I think it's important that, that you decide, do you want to stop at this point of time, or do you want to do additional testing? And I think if you are sort of seeing somebody who's stable, it might be appropriate to sort of stop at this point, treat symptomatically, and call them back in a period of time to sort of reassess. And I think that is important so that we don't send multiple tests and then end up with more tests and still no diagnosis.
Yeah, Shiva, and you spoke about rapid diagnostic tests, but there are a lot of issues with that, with their different sensitivity and specificity for different infectious diseases. So can you throw a light on this, like which specific diagnostic tests are useful and which are not?
It's important to understand that, a test is the part of the same Bayesian process of hypothesis testing. You've arrived at the end of your history and physical exam to a certain pretest value. And that's based on your prevalence. That is refined by your history and physical examination. And that is only refined further based on your diagnostic testing. And if you don't have the appropriate pretest probability, which needs to be around 30 to 70%, then don't do the test. Because if you're 90% certain that it's the diagnosis, why do you want to test? If you're 20% likely that the diagnosis is, something, then your diagnostic utility is not improved substantially by testing, even if a test is 70 to 80%, sensitive or specific. And so no test is perfect. I mean, a test is only as good as the person who's ordering it and interpreting it. And I think we sort of have to overstate this because, you read of sensitivities and specificities and you get swayed by that. But, you can use a completely nonsensical test on somebody and get a positive result and you don't know what to do with it. So, in terms of tests, individual tests, since we sort of brought up malaria, I think what's rapidly emerged is that the malarial tests have a sensitivity and specificity, which is in the range of 85 to 90%. It sort of differs by the type of test. So, in the past, the gold standard used to be the malarial thick and thin smear, but I think it's estimated like a thick smear has to be read for at least 20 minutes with over 200 fields for it to be reliable to rule out. And so there is the observer technique where the malarial smear sort of suffers in terms of sensitivity depending on the training and depending on, how diligent, if somebody's getting like 20 smears, that obviously sort of buys into their time that you're spending processing the smear. It's fair, it is not a function of the sensitivity of the test itself. Like I think the malarial smear is more sensitive if you compare the parasitemia of a smear versus an RDT for the same amount of parasitemia. I mean, I think the malarial smear can detect up to 5 to 10 parasites per microliter, and the RDT sort of drops below 100. But I think it's the time intensiveness or the personnel intensiveness that sort of affects it. And also, people who treat patients with falciparum realize that sometimes falciparum can sort of be aparasitemic or sequester. And so a negative smear does not rule out. But then I think the RDTs, where the convenience comes from is the fact that they're deployable. And then they have reasonable sensitivity and specificity for moderate parasitemia. So that's like more than 100 parasites per microliter. But, obviously when you have something that is on the field, you want to make sure that there are not storage conditions. Like, for example, temperature extremes might affect the reliability or how the test is interpreted. For example, if you're using a colorimetric test, and we've sort of gone through this during COVID, right? My line is faint positive, or my line is maybe I'm seeing a line, or I want to see a line, right? So I think those things have to be accounted for. I think the other thing that the tests don't tell you is the degree of parasitemia, right? So you don't know if somebody has a parasite index of 10 and sort of needs escalation of care. There are two test assays, there are many test assays, but they're based on either the histidine-rich protein Plasmodium falciparum, which tests solely for falciparum, which is highly sensitive and specific, and the LDH is sort of tests for falciparum and vivax and other species, but it's slightly less sensitive, but is also very specific. So in other words, a specific test means a positive test rules in, a negative test does not rule out. So when you use tests that are sensitive and you use multiple tests, bear in mind, when you use sequential testing, the specificity increases. And so what that means is that if you have two negative tests, then it sort of makes malaria unlikely. Or if you pair, an RDT along with a smear and they're both negative, then makes it less likely. But two negative tests make it highly unlikely. Now, the one caveat I wanted to bring up, and I think this is because maybe the surveillance data might be lacking behind, but there are histidine-rich proteins sort of negative falciparum malaria that exists. It's a small proportion in India as compared to sub-Saharan Africa, but the cases reported out of Orissa and Gujarat, which might give like a false negative with a falciparum RDT. And so if you suspect, then sort of consider doing a smear or doing an LDH test. The second test that we quoted in the rapid pathway was probably the dengue test, right? So the dengue test is not as great, but it's certainly somewhere in the middle between, the leptospirosis and the typhoid test, which are completely rubbish in my opinion. And so I think, various, studies might sort of give them a sensitivity somewhere between 75 to 80% or so. So less than malaria. And there is an antibody IgM capture, which will sort of detect earlier dengue and then, later dengue, and then the NS1 antigen, which is detect early. So the first 5 days, you might have an antigenic phase. The later phase, you might have an antibody phase. And so if you combine the two, the goal is maybe you can detect it across the spectrum. In many cases, you might probably have a strong suspicion and you might choose to test, but more so to sort of be reassured or elevate your pretest likelihood. And you might choose to disregard or overrule a positive or a negative test if your pretest suspicion is fairly high. And that happens fairly commonly in dengue. And then, I think this is sort of, then we talk about maybe, enteric fever. I think traditionally blood culture should be the gold standard for diagnosing enteric fever and probably should be the only method used to rule in, not to rule out. And I think the reason being that, we talked about blood cultures and, gram-negative bacteremia, right? And so why do people with typhoid have symptoms for 3 to 4 weeks? The fact is the amount of Salmonella typhi in your bloodstream is probably much lower than, let's say, E. coli bacteremia and somebody has pyelonephritis. It's to the order of 2 to 3 colony-forming units per ml versus, much higher in, when somebody has a gram-negative sepsis. And so you obviously have to sample more blood. And so the pooled sensitivity usually is somewhere in the range of 60 to 65%. And so it also drops with time, right? So you have a bacteremic phase and then subsequently you have an immune phase. And so the sensitivity will be higher in week 1. Week 2 cultures, it's much, much more lower. And so I think it's important to sort of consider that when you're, testing for typhoid fever. Make sure that that you draw an adequate amount of blood. You should be drawing probably around 15 to 20 ml of blood. The more, the better, because obviously, we talked that the colony-forming units per ml are much lower. serology, every medical student in India gets taught about the Vidal test. Please don't use the Vidal test. Its performance characteristics are extremely poor. And sometimes I get confused when patients sort of forward me a Vidal result and I don't know what to do with it because it is limited by sensitivity, it's limited by specificity. But I think if you're in a setting where you don't have blood cultures and, you need to send somebody to a medical college for blood cultures, and if the only test that you have is Vidal, and if the patient is weak too, and your suspicion is low, then, the negative predictive value might be reasonable. Negative as in, if the test is negative, then your suspicion should be lower in terms of like the patient having typhoid. It's not fantastic, but it's still maybe sort of lower. People use the Tubex and the Typhidot tests. They're all both, in the 60% sensitive range. So to my mind, if your test is slightly better than a coin toss, I would rather toss a coin, right? To know if I have a positive test or a negative test. And so why should I depend on a test that is 40% going to be, falsely negative, right? So I think, again, I think it's important to remember that when these performance characteristics are tested, they're tested against a gold standard. And so that gold standard is also not perfect in typhoid fever. The gold standard in terms of sensitivity would probably be a bone marrow culture or a PCR if one were available to do that, or to demonstrate, Salmonella typhi in every single patient that you sample. So in most of the assays, when they tested, they compared against blood culture positive Salmonella and some other organism growing in the blood as a negative gold standard. So that's important to remember, because I think typhoid fever is one setting where you might need to sort of consider, do I need to do a blood culture, and do I have access to a blood culture? Can I treat without a blood culture being available? And, obviously, I mean, if somebody presents with respiratory symptoms, you're in the middle of a influenza surge, should I be doing a flu antigen for COVID antigen if I have access? Access has improved, but it sort of varies depending on, if the setting, and also if somebody has access to, self-testing as well. I think the really dirty, muddy area is scrub typhus, leptospirosis, chikungunya. And, I think there are various tests that are used. I mean, leptospirosis, the problem is they're all serologic tests. And to my mind, serologic tests, the gold standard is a 4-fold rise or a 4-fold fall. And if you don't have a 4-fold change in titer, you're stuck with tests that have varying, thresholds of cutoffs, and they're tested in different settings. So, for example, leptospira, we used to use, in Mumbai, we used to use the STRIDOT, which is sort of based on an IgM-IgG assay. And early on in the illness, the test might be negative. So if the test is negative, you're telling your patient it's negative. Sometimes you might want to sort of retest, because as we talked about, there is a initial parasitemic phase, and then spirotechemic phase, and then subsequently an immune phase, right? So if you test somebody early and then you retest in week 2, and if that's positive, maybe that helps more than depending on one single test. But there are titers that are suggested, but again, somebody who's had leptospirosis in an endemic area in the last year can still test positive with an IgM assay. So, when you consider that, you might not want to test perhaps. Also, there are, high endemic areas. So I'm talking about like people who are in high exposure to rodents. So for example, sewer workers, or people who reside in temporary tenements in urban settings, or in hyperendemic areas. Like, for example, the Andaman Islands is supposed to be hyperendemic for leptospirosis. So asymptomatic people who are sampled from these populations might have a high backgrounds of, test positivity, and that's up to like half of everybody. And so, you need to sort of keep that in mind when you test. And so also for, scrub typhus and chikungunya, and it probably, maybe, there is an immune fluorescence assay, there is an ELISA assay, but they're notoriously sort of unreliable because of high background positivity. And you'll see a number of published manuscripts that quote diagnosis based on this. And you want to sort of question, because the prevalence varies from like up to 50% of cases being scrub typhus. And you wonder sort of, is that high, that prevalent? But, I think the background test positivity or test positivity from prior infections probably contributes to maybe some amount of overdiagnosis in that case. So that's it, and that's important to remember. And since we talked about mosquito-borne illnesses, I think the one thing that I also wanted to point out is it's not uncommon to have dual diagnosis. Let's say we did that shotgun approach where we offered everybody like a multiplex panel and tested on every single infectious diagnosis. Asymptomatic parasitemia and malaria is not uncommon, and you might sort of pick up like malarial parasitemia in somebody who's bacteremic. Similarly, if you're using a serologic test where you have the Aedes mosquito, you might test positive for chikungunya and dengue, and it's not uncommon. It could be up to like 10% of cases. So that's sort of the limitation in your diagnosing based on serologic tests and conditions that are, highly prevalent or endemic in a similar setting. So I think, when you're using rapid diagnostic tests or serologic tests, approach them with an appropriate pretest suspicion. And in your mind, I think this is something that I would like to emphasize. Think about, what if this test is positive? What am I going to do? What if this test is negative? What am I going to do? I think that's a useful question to ask before you use a test, because again, as we talked about before, you might end up with snot in your hand and not know what to do. So I'll probably pause there. I have a lot of strong feelings sometimes with serologic tests, but maybe that's for a private discussion. But I think approach the test with some measure of both respect, but also skepticism. So I think Gajanan, you have a wealth of experience to contribute in terms of management, right? So in light of all of this theoretical discussion that we sort of had about managing acute undifferentiated fever, you're at JSS, you're seeing somebody who presents to the clinic. How would you sort of approach, somebody who presents in your clinic with an acute undifferentiated febrile illness? Any of these diagnoses possibly?
Yeah, sure. So that is a very important question, I think. And here at JSS, we also have a referral hospital and we have sub-centers or health and wellness center. So the malaria test is a must. So we do keep the malaria test at our sub-centers and at the emergency room we have at the hospital. So it's there only in bedside. And we want to reduce the turnaround time, so we don't send it to the lab. So whenever we get the sample, we do this GRBS and the malaria test immediately. And if it is positive, we know this is malaria, and then we have to see for other things and start the treatment immediately, because the malaria, when is non-severe, it's easy to treat, but when it becomes severe, then it is a nightmare, especially when you are in a low risk. And nowadays we are seeing more dengue patients. So it's being transitioned from urban settings to the semi-urban, and now also coming to rural areas. So with the history of myalgia, thrombocytopenia or rash, we have a high suspicion of dengue. So at that time, we will do the dengue test, which is NS1 antigen. But that availability is varied. So sometimes we have this test, sometimes we don't have this test. So whenever we have a high clinical suspicion, and dengue doesn't have a specific management, it's just an observation. So we just ask the patient to follow up after 2 to 3 days. The same is for any undifferentiated fever. So because we have a limited access to scrub or lepto tests and the blood cultures, although we have it at our hospital, but it's costly. So we do reserve it when the patient had some abnormal presentation, or when the patient is in shock. So otherwise, we do treat patients empirically with antibiotics.
Great. So since you sort of mentioned empiric treatment, or sometimes when there is no empiric treatment, maybe symptomatic treatment, how do you decide, or what sort of treatment will you provide? Let's say, you have one of our patients in the case scenarios who's coming to see you, not the shocky person, maybe perhaps somebody who's in between. What sort of initial treatment would you provide? And then how do you decide, who gets empiric treatment and what will that be? Curious to hear your thoughts. I think since, you have a lot of practical pearls to provide.
Yeah. So Shiva, as we discussed, most of these patients will have viral infections. So the role of general supportive care is very much important here. So adequate hydration, rest, and getting fever down with paracetamol or tepid sponging is important. I see sometimes the dose of paracetamol used is less. So we have to remember the dose of paracetamol is 15 mg per kg. So it can go higher, up to 1 gram a dose for an adult with a good weight. and the maximum dose we can go is up to 4 grams per day. So we have to really dose the paracetamol very well, and we have to give it 6 hourly. So if we don't give it 6 hourly, the fever will be there, and then patient will go to another doctor, will seek undue antibiotics, even though it's a viral fever. So getting fever down, and also with the fever gets down, the appetite is good, the hydration is maintained, so it causes less symptoms. And to maintain hydration, we can use ORS, and if the ORS is not available, even like home-based ORS or lime water is enough. And in this, after COVID, we have seen patients with desaturation, but without any presentation. So we call it silent hypoxia. So monitoring oxygen saturation and asking patients come back after 3 days is important if we are suspecting viral fever and our initial tests are negative. So, but if we have a malaria test positive, and with the RDT, we will know whether it's falciparum malaria or vivax malaria, then we can treat it with antibiotic. So suppose this is a vivax malaria, we know that we can treat it with chloroquine in this region. So the dose is like 600, 600 and 300. So that is 1500 total. Or in terms of milligrams per kilogram, so it is 10 mg per kg on day 1. So that usually is 4 tablets. And then the same dose on day 2. And then 5 milligrams per kilogram on day 3. And along with that, we have to give primaquine, which is 0.5 milligram per kilogram per day for 14 days. So this is for vivax. And suppose it is Plasmodium falciparum. So here we use artesunate and sulfadoxine pyrimethamine. So the dose of artesunate, if it is non-severe malaria, it is oral. So 200 mg for 3 days. And along with sulfadoxine pyrimethamine, which is 750 mg. And pyrimethamine is 37.5 milligrams. So single dose. And in primaquine, in falciparum malaria is also a single dose. And the mg per kg dose is same, that is 0.75 milligrams per kilogram. But if it is a falciparum malaria in northeastern state, and we know there is emergence of resistance to artesunate, so we have to use this artemether plus lumefantrine. So the dose is 80 and 480 milligrams, so which is 4 tablets into 3 days. And obviously, we know like primaquine is contraindicated in infancy, in pregnancy, and in individuals with G6PD deficiency. So this is all about malaria.
Yeah, that's, you brought up like really great points. I think one, making sure you manage the fever and keep the patient away from the Jola Chap doctor, right? I think, since our focus is evidence-based practice and making sure the patient gets the right treatment. I mean, I'm quoting from, from publications that from Jishnu Das and their group in terms of like inappropriate treatment from general practitioners in urban and rural India, right? So I think it's important to retain your patient base, as we call it. And I think that's very important, making sure fever is managed because, contextually, I think for a patient, maybe their fever matters more. For us, making sure that they don't get sicker matters more. So I think, managing the fever was a very great point that you brought up. I think the one thing that I'd like to, also point out from my management of malaria is chloroquine and its emetogenic potential, and warning patients of side effects, telling them, hey, you're taking chloroquine, you'll have nausea and vomiting, make sure you anticipate that, or I'll give you some medication for that. So that somebody doesn't take chloroquine, then stop and then come back. I think those are just sort of, maybe some practical pearls that I wanted to sort of also bring up. But, obviously malaria treatment is systematic. It's built in the national guidelines and is fairly sort of made systematic so that, there is more compliance to the pathway. But, what about like the non-malaria, febrile illnesses? Because as we sort of said, you have the rapid diagnostic test and you might have the results for malaria, but you might not have the results back for some of these other tests. So how would you approach somebody who's presenting with what is clearly, you've ruled out malaria, you've done your rapid diagnostics and you've said that this is not likely malaria. You had like 2 tests and they're negative.
Yeah. So, this is a pretty common situation that the patient present with acute undifferentiated fever and the malaria test is negative and there are no localizing signs. So what to do that? So we have like you discussed in detail about different rapid diagnostic tests. Sometimes we don't have them, but sometimes we have them. But the principle is, will it change the management? If I get the result back, will it change the management? For influenza, so in a patient who is well-nourished and who doesn't have any other high-risk factors, so will not go for an influenza RDT. And influenza RDT is also difficult to access in India. And if the patient is at high risk, directly I would start oseltamivir, the recommended doses. And for others, so like say for enteric fever on scrub and lepto, I agree with you that Vidal is a very dicey test and it should not be used. So rather than using that, we'll go for empiric antibiotics and we'll choose the antibiotics which will cover like all these three. And fortunately, the antibiotics for this is common. So if we start patients on ceftriaxone and doxy, if the patient is sick and we are going to admit it, then both IV, then it will cover both enteric fever and scrub lepto. We know now we have case reports where doxycycline works better for scrub and lepto than azithromycin. So I would start that. And if the patient is not appearing sick and if we can manage him on the OPD basis, we are suspecting enteric or scrub lepto, then I would start cefixime. The dose is higher here, so 400 mg twice a day for say 5 days. And I will add oral doxycycline to this to cover scrub and leptospirosis. But if someone is systematically ill, then I would say admission and then starting empirical treatment with ceftriaxone and doxycycline.
Yeah, those are very interesting points. I think I'd also maybe point out at this point, part of your assessment of severity maybe is also assessment of whether the patient can swallow as well or they're able to sort of keep medications down. We talked about chloroquine, but sometimes doxycycline, remember, can sometimes cause a piloesophagitis. So if somebody's taking doxycycline, they need to take it with a full glass of water, stay erect for at least an hour after they've taken doxycycline. I think that's something that we tell patients all the time. Amongst our list of when we poll ID physicians, certainly in social media sometimes, what's your favorite antibiotic? Everybody likes doxycycline because it's there's such a wide spectrum of conditions that it covers low, side effect profile otherwise in terms of as compared to other antibiotics. And azithromycin is a great antibiotic in terms of not just, the spectrum of activity, but also the intracellular activity or the wide volume of distribution such that, you can dose it once a day and sort of persist in the tissues for a longer period of time. And then the other point is that I also wanted to ask is, I think how accessible are blood cultures? Does it involve the patient making a trip to some? Is it an access issue? Is it a cost issue? How do you make a decision as to? I mean, you said if somebody has shock, obviously you order blood cultures, but let's say somebody is in that period between 1 to 2. At the end of week 1, they have a fever. You've seen them for the second time. Would you at that time, when do you do blood cultures?
So an average blood culture, so at our hospital, it will cost about 800 rupees, but in private hospital, it will cost more. So sometimes the empirical treatment is cheaper, easily accessible, and is acceptable by the patient. And the only thing is patient should accept to follow up after 48 hours. But at other times, if the patient is not willing or we are doubtful, then we'll definitely send the blood culture. Otherwise, I would send blood culture when the empirical treatments are not working, if I am seeing the trend of there is more tachycardia, there is hypotension, and the CBC trends, say there is more leukopenia or there is higher leukocytosis. So those will be the points that I would look and then order the blood tests.
I think you brought up the cost perspective, right? I think when we look at blood cultures, we also, certainly with the emergence of malaric acid resistance with, fluoroquinolone resistance, I think, and maybe you and we had sort of conversed in another portal about this, but in terms of susceptibility testing, is that fairly reliable and easily available?
If we have an automated machine, the positive results or negative results are more reliable. But when we do it manually, the results are not that so good. And I would say they are little unreliable. But with automated machines, if they are available, the reliability is good, the identification is good, the susceptibility pattern is good. And there we can actually trust. So whenever that is helpful in terms of shock. So if there is an acute undifferentiated fever with shock, say I would go for an antibiotic duration of 10 days or 14 days, and there blood culture would be cost effective if it grows and that it gives us an antibiotic sensitivity, and also it will generate some data for the epidemiological point of view where the patient cannot afford blood culture or there is no access for the blood culture. So that way the blood cultures are useful in patients with shock. But otherwise, I would say if there is no automated blood culture machine and then I would not go for it and start empirical treatment.
Yeah, and I think you brought up a very important point of like making sure that they follow up. I think that's like a second point of contact, and then emphasizing one, I think maybe reassessing them. Two, also emphasizing that to if the treatment is working, keep taking the treatment. If the treatment is not working, then we need to do something else. So I think it's I don't know how to sort of underemphasize the important. I think that's, if there is one important thing, that's the reassessment. Again, undifferentiated fever, the more number of observations you have, the better the diagnostic accuracy. So, but in terms of, I think you touched upon cost, but what about turnaround time? The rapid tests are fine, but tests that are sent out to either the local lab or outside, is that a major barrier when you're making decision what to order, but also sending tests?
Yeah, Shiva, you are right. So that's a significant challenge. So because the turnaround time is actually like 7 days or 10 days, and by that time we already know the patient is improving and worsening. So this is a major hurdle when sending the blood culture.
Absolutely. They're all formidable hurdles. I think I think we need to sort of have, as we talked about, maybe if there is one message is use your clinical tools, refine your clinical suspicion based on history, physical exam, and your initial workup, and follow a systematic approach. Make that patient lie down, palpate their spleens or examine them, make sure they don't have a rash or a murmur. I think it's also, I think the important point that you also brought up is like empiric treatment maybe is contextually important in certain situations, but it's also important to avoid indiscriminate antibiotic use. And that sort of both serves the patient, but also in the long term, I think we want to emerge out of this, label that we have of antibiotic abuse and misuse and antimicrobial resistance capital of the world. I think as we as providers should maybe use our portal that we have to sort of try to educate our peers and maybe our juniors, because they're going to carry things forward. And I think these I think would be sort of broad messages, and I'm hopeful that that this discussion, if people are listening, is useful in terms of both from the theoretical perspective but also from the practical point of view. How do you approach? And I think we should not also hesitate to reach out or talk to people. I think there's a lot to be learned, and it's not necessarily sort of doesn't show you in a lower light if you sort of ask for assistance. I think it's the more knowledge we share, the better it is. So thanks, Gajanan. I think I really appreciate some of the practical pearls, but I'd like to pivot and maybe with these topics that we sort of brought up, go back to our initial two cases, and maybe we can use that to wrap up our discussion. So maybe you can take one and I can take the other. So I'll probably read out the first one to you, because maybe this is somebody from that you might probably see not in common. So this is, again, to remind our listeners, this is a 35-year-old rural farmer from West Bengal, let's say Chhattisgarh, who presents with a 5-day history of high-grade fevers, chills, and then severe headache. And then he denies any cough, diarrhea, or urinary symptoms. And on exam, he's dehydrated. His temperature is 102 degrees Fahrenheit. He's tachycardic to a heart rate of 110, and his blood pressure is 90/60. So, Gajanan, he's with you.
Yeah, sure. So with the farming occupation, there is exposure to rats, and then with his vitals, I see there is higher temperature, there is tachycardia, the BP is going low, and there is no localization. So here I would see the differentials would be like either malaria, scrub typhus, or leptospirosis or dengue. And with these, I would say, like with the seriousness is presenting, so the lepto or malaria is higher. So like let's do the malaria test, and if it's positive, then treat malaria, and if it is negative, then it would be more likely leptospirosis. So for that, if the rapid test is available, then go for it. Otherwise, we'll do CBC, SGPT to assess liver, and serum creatinine to assess kidney. And then see the result, and then start empirical antibiotics as we discussed, like with ceftriaxone and doxycycline. And important thing is like not to forget the follow-up. Yeah.
Could you just speak a little bit about like why ceftriaxone and doxycycline? I think just to reiterate what we talked about previously.
Yeah, so ceftriaxone is a broad spectrum antibiotic. It will cover like enteric fever, as well as it will cover rickettsial infections. And doxycycline, we know, like you said, it is the favorite antibiotics for ID physicians, and it also has a broad spectrum, and it covers rickettsia well, and it has a nice sensitivity pattern because it is not being abused like any other antibiotics.
Got it. Great.
Yeah. And let me read out the case number 2 for you. So a 28-year-old pregnant woman from a poor locality in Mumbai comes to the clinic with a 7-day history of fever, myalgia, and rash on her arms and legs. The temperature is 101 and she appears ill, but is hemodynamically stable. So blood tests reveal thrombocytopenia and a platelet count of 80,000 per micron. So she comes to you. So what do you suggest?
I think from the presentation, it seems like she's stable. She has fever and myalgia and rash and thrombocytopenia. So this is sort of our FARD or FARC patient that we talked about earlier. So this seems fairly convincing, for a diagnosis of dengue. So, Mumbai is sort of endemic for malaria. And so, if it's the season, then I would sort of consider a rapid diagnostic test for malaria. And also, especially if there are other clues, if they have splenomegaly, if there is evidence of mild hemolysis, if the LFTs are elevated, my suspicion is sort of heightened. I may or may not get a dengue test. I mean, I would consider it if there is an appropriate situation, but I think bear in mind, it seems like it's fairly, the patient is stable. How much is my test going to sort of change the management? Sometimes you might sort of see, in your CBC, you might see sort of signs of hemoconcentration or leukopenia, sort of other clues that I will scan in the reports and sort of look up at. And look for any petechia that might be sort of signs that will heighten my pretest likelihood. Sometimes, these patients might come to you with a chest X-ray that somebody did, and so you might see like a mild pleural effusion, which is a sign of capillary leak and dengue, or they might have some peripheral edema. So she's stable right now, so I would probably, if, regardless of the dengue test, I would sort of treat her then as dengue. But I think it's important to remember that, dengue in a hyperendemic area might mean that there is repeated exposure, and this could be a second episode. And so warn for or bring the patient back in 2 to 3 days just to make sure that they're not evolving into, dengue hemorrhage or severe dengue, as we sort of tend to call it now. I think that would sort of be my approach. Again, I would, probably use the same tools, make sure that they're taking paracetamol, managing their fever, and then warn them about signs of, that might indicate clinical worsening. So yeah, that would be my approach. I don't think we're where I would want to order more tests unless I see the patient back. And I think maybe emphasize to the patient that, come back, when I see you in 2 to 3 days, maybe we can decide if we need to do any more tests.
Yeah. Thank you, Shiva, for this insightful and detailed discussion. I feel this discussion has really been helpful to highlight the complexities of managing acute undifferentiated fevers in India, and it needs a comprehensive approach and an evidence-based approach. And also we discussed the unique challenges that we faced in this country. Thank you.
Thanks, Gajanan. I think this was very insightful. We're hopeful that, this discussion sort of generates both, learning points, but also questions for trainees and for peers, just so that they can, use the tools that they have better to, manage undifferentiated febrile illness. And I think both at the individual patient level, but also, if you know something, teach somebody, spread the knowledge around. I think, talk to your peers. Hopefully this is useful to our listeners, and please stay tuned for more episodes on clinical pathways. To our listeners, this is the end of the Acute Undifferentiated Febrile Illness Pathway as a part of the Community Science Alliance podcast. Thank you all.
This is the CSA Podcast, presented by Social Alpha.